Hi, thank you for giving me this opportunity to present the Child Health and Mortality Prevention Surveillance Network, or CHAMPS. CHAMPS is a Bill and Melinda Gates Foundation-funded surveillance network that has three main objectives. The first being to track the definitive causes of child mortality in sites where there's a highest under 5 mortality in sub-Saharan Africa and South Asia, and also to produce and disseminate this high-quality data to ultimately inform policy and public health action so these deaths can be prevented. And finally, provide a platform for other work and services that can aid in the prevention of mortality. CHAMPS is currently active in 7 sites, 2 in West Africa and Mali and Sierra Leone, 2 in Central Africa and Ethiopia and Kenya, and 2 in Southern Africa, Mozambique and South Africa. 1 currently in South Asia and Bangladesh, and a second one will be incorporated in the next year or so after pilot activities in India conclude. Our CHAMPS network is fortunate to have strong scientific and public partners at each of the sites and external collaborators as well. This slide captures just a few of them, including in each of the sites, as well as external international partners, and the partners included in the program office, which include the Emory Global Health Institute, where it is the awardee of the Bill and Melinda Gates Foundation grant, as well as technical partners CDC and East Global in the INDEP network, IAMPI, which is the International Association of National Public Health Institutes, and the Public Health Informatics Institutes and the Task Force for Global Health. So at each of these sites where there's current CHAMPS activities, there is a defined catchment area and where local teams lead each of the CHAMPS processes. Due to the sensitivity of the CHAMPS work, namely identifying child deaths, the first step in this cycle is community assessment and engagement, and the strong social behavior work lays the foundation for the acceptance of the surveillance component. Surveillance component includes demographic surveillance, or DSS, so that a denominator is available for calculating site-specific cause-specific mortality rates that can then be used in extrapolating CHAMPS data to the wider area. In addition to the mortality surveillance, we're also incorporating pregnancy surveillance at all of the sites to ensure that all stillbirths and neonatal deaths are captured, as well as looking at maternal risk factors. Once a death is identified and consent is given for the CHAMPS program, all clinical data and VA data are collected on CHAMPS enrolled deaths, as well as in the cases where the body available and the family consents, a minimally invasive tissue sampling procedure is done. In this procedure, which is standardized across the CHAMPS network, which includes provision of a specimen collection kit that has all of the tools necessary for the procedure, including the biopsy needles, as well as collection containers that are pre-labeled with unique IDs. The specimens collected during this procedure include blood, CSF, NPOP swab, and stool, as well as tissues, liver, lung, heart, brain, and bone marrow, which is being phased out, and in stillbirths and early neonatal deaths where the placenta is available, that is collected as well. In addition to the specimens, the procedure also includes photographs of the body to look for any congenital or gross abnormalities, as well as physical measurements, so that we can also assess the nutritional status or the contribution of malnutrition to under 5 mortality. The specimens that are collected undergo a wide array of diagnostic testing, and this includes microbial culture of the blood and CSF, standardized HIV, TB, and malaria testing on the blood. And something unique to CHAMPS is TACMan array card. So this is a multiplex real-time PCR platform that in the combination of the 5 specimens, blood, CSF, and POP swab, the lung tissue, as well as the stool, over 5 different cards, we can test for over 134 pathogens. And then also unique to the CHAMPS in this MITS procedure is the addition of looking specifically at the tissues by histopathology to identify any causes that can contribute to death. At each of the sites, all of this testing is done locally, including the pathology and looking at routine histology by H&E stains. Additionally, an aliquot of the tissues are sent to the Central Pathology Laboratory at CDC in Atlanta for more advanced pathological tests, including special stains in immunohistochemistry. In the future, this capacity will also be transferred to the sites. But in the meantime, we also include telepathology as the CHAMPS procedure. And this is routine sessions between the experts at the CPL or additional external pathology experts and each of the site pathology teams, and sharing the images and discussing the images. CHAMPS built a platform so that images can be easily scanned at the site. Whole slide images can be easily scanned at the sites and then uploaded to create a library of these very useful images that can help in the diagnosis of causes of under 5 mortality. So in all of these cases where all of the testing is done and all of the other clinical and verbal autopsy data is collected, this then goes to a panel of experts at each of the sites to discuss the case and come up with the cause of death. And these panels are the determination of cause of death or DECODE panels. And each of these panels at the sites, again, are made up of clinicians, pediatricians, neonatologists, OBGYNs if available, pathologists, microbiologists, and other laboratory specialties, as well as public health specialists or epidemiologists. And they look at all of the data for these cases that undergo the MITS procedure. And so this includes basic demographic data, the verbal autopsy, which is an interview by the family asking for specific signs and symptoms that led up to the death, as well as clinical abstraction of both the child and the mother, if applicable, on the perinatal deaths. And then all of the diagnostics that is included in the CHAMPS protocol, including the anthropometrics and the photographs, the blood and CSF culture, the HIV, TB, which is done by gene expert, the malaria, and the TAC results, which include all of those up to 134 pathogens that are detected, as well as the pathology results from both the site and the CDC or the Central Pathology Laboratory. The whole slide images that I mentioned during the telepathology are also available to the DECODE panelist if needed during the session. And the ultimate result from this DECODE panel is to basically fill out a WHO death certificate, which is shown here. And this includes determining the underlying cause of death, or that disease or injury that initiated the whole chain of events that directly led to the death, and then all of the antecedent or morbid causes in between, as well as the immediate cause of death. Is that the disease or the complication which directly preceded or led to the death? One thing that in these sites where there's high under 5 mortality in that CHAMPS is established is that just simple enumeration of the deaths was not even occurring. So in addition to that, we are providing more granular, detailed information leading to the death. And using the WHO ICD-PM or the application of the ICD-10 during the perinatal period, we recognize that maternal factors do contribute a lot to these perinatal deaths. And so our DECODE panels put the results of the perinatal deaths in this form, so listing the main disease or condition that occurs in the fetus or infant, as well as capturing those maternal factors that contributed to the death of the fetus or the infant. Our DECODE process, we put a lot of work into making sure that it's standardized because, as I mentioned before, this process occurs locally at each of the sites. So there could be an inherent bias or variability between the sites. So some of the standardizations that we put in place in the development of the DECODE process is to adhere to the WHO guidelines for certifying a death, both by the ICD-10 and ICD-PM, as well as providing standardized training at each of the sites. And importantly, we developed what we call the diagnosis standards for interpretation of the complete CHAMPS data. This document is a living document, and the intent was to, again, provide the guidance to standardize the interpretation of CHAMPS-specific data elements across the DECODE panel and to assign individual diagnosis. And basically, these are case definitions that use any clinical symptoms that could potentially be available through the various medical abstractions across the sites. More importantly, to take the results from the CHAMPS diagnostics and put them in interpretation with the clinical signs so that if we say there's a pneumonia happening at one of the sites, it can be comparable to a pneumonia happening at another site. They provide guidance for individual diagnosis, but not necessarily where that diagnosis fits in the causal chain. Again, that is dependent on the case, each individual case, and the circumstances of that death. Importantly, it's not an exhaustive list. And as I mentioned before, it is a living document. So as we acquire more data and learn more of the things that we are seeing, this document is always updated. Shown here is just an example of one of the diagnosis standards. And so we have the diagnosis standards titled, but also including what ICD-10 codes that it would be applied to. Again, to help standardization, but also to help the DECODE panelists as they're having discussions. There are 3 levels that are assigned to each diagnosis standard, and these are comparable to levels of confidence. That's where the specificity to the CHAMPS diagnostic comes in, because the level of laboratory evidence or other evidence for level 1 means that there's very strong evidence seen by the CHAMPS diagnostics versus level 3, which may just be clinical signs or signs that were captured in the verbal autopsy. And then finally, for the DECODE standardizations, we have an external quality assurance process. Currently, this involves 2 steps. There's a virtual interpanel assessment. The cases that have been adjudicated by the local sites every so often are shared between the other sites. So for some cases, we potentially could have up to 5 or 7 different diagnoses or different causes of death filled out. For the first rounds that have occurred since CHAMPS has started, it's actually very high concordance between sites on cases. In those cases where there is not 100% concordance, it's mostly due to local context, which is very important when we're looking at individual cases, as well as cases where there's not a lot of clinical information and the laboratory testing may not be as strong, that there is some different speculations. And so from those processes, we learn, again, more how to change some of the diagnosis standards or refine them so that the standardization can keep improving. We also bring together our panels on a routine basis, either as a large group or for specialized pathogen-specific or condition-specific. For example, just recently in the last few months, we've brought in experts for Group B streptococcus to look at cases where Group B strep was detected by multiple ways in cases, but the panels did not necessarily feel that Group B strep was a causative agent in the death. And this expert panel, again, agreed that the standardizations that are in place and the interpretations are very accurate because there was close to 100% concordance with their assessment of the cases compared to the original local site. So after these cases that undergo this DECODE panel with cause of death determination, the most important step in this CHAMPS process is giving that feedback back to not only the family and the community, but also, again, to put into aggregate data that can be used to inform policies or interventions to reduce the under 5 mortality rate. An example showing this is presented here. So this was a female stillbirth that had a estimated gestational age of 35 weeks, and the weight at the delivery was 3.8 kilograms. The mother was a 20-year-old HIV positive, but on treatment, was diagnosed prior to the pregnancy. This was a twin pregnancy. She had 4 antenatal care visits prior to the delivery. The fetus, the postmortem HIV, malaria, and TB testing were negative. The other twin was born alive with an APGAR score of 7 and 8 and weight of 2,000 grams. At the time of the delivery, the condition that resulted in the stillbirth was obstructive labor. The TAC for this, or the multiplex PCR that was done on this case, was positive for treponema pallidum, or syphilis. And this was extremely correlated with the immunohistochemistry and the pathology results. In the image on the left, which is the liver, all of that red staining is immunohistochemistry, or looking for antigens of the treponema pallidum, or syphilis. And as you can see, there is an overwhelming amount of pathogen there, as well as very little normal liver tissue. The lung and the brain were also seen to be positive by immunohistochemistry for the pathogen. In addition, the placenta showed not only histology or histopathology, but also immunohistochemistry evidence of syphilis. These important findings were relayed back to the family, and the mother and the twin were tested and were able to be treated due to the results from the CHAMPS. And as you remember, I mentioned previously that originally this stillbirth was assumed to be caused by obstructive labor. But here's where CHAMPS had an immediate impact and data to action, and that the family could receive these results and actually get treated to hopefully prevent this in the future. So currently, over 2/3 of the CHAMPS cases are stillbirths in neonates. As of today, there have been over 1,400 MITS procedures done on these under 5, again with 2/3 being stillbirths in neonates. And the numbers do vary across the sites due to when the sites initiated as well as their under 5 mortality rate. But of these 1,429 MITS that have been conducted, over 1,000 of them have gone through this decode process. So there's cause of death data available on 1,000 of these cases. Again, across 5 of the sites, our 2 sites that just started in the last few months, Sierra Leone and Ethiopia, will have cause of death data by the end of the year. So as these numbers keep increasing, not only of the MITS procedure and CHAMPS in general, but also of the cause of death data, we'll be able to inform important questions concerning under 5 mortality. And for example, some are listed here. So malaria, how much mortality at what ages and sites are due to malaria, and then what is the role of co-infections in these cases? Pneumonia could answer many things. 2 example questions are how much does RSV and group B strep contribute, and could this be preventable by maternal vaccination? What are the leading causes of sepsis in neonate and children that are dying of neonatal sepsis? Our diagnostics are right now very skewed toward the infectious cause, but we also are interested in looking at non-infection causes, including malnutrition, but also what is the contribution of sickle cell disease to under 5 mortality. And then again, nutrition, what portion of the preventable deaths does malnutrition contribute to? Important and unique to CHAMPS is that all of the data is open access, and this includes aggregate data visualizations in real time at champshealth.org, as well as curated limited data sets that can be immediately downloaded, which include the case demographics, the cause of death determinations with the ICD-10 codes, but also the categorizations and the etiologies. The verbal autopsy answers, and so again, that is the postmortem interview that's given to the family about signs and symptoms leading to death. Some of the clinical laboratory results, and also the results from the Tachman array card, results of multiplex PCR. Additional data can be requested that include some identifiers, and in the future, there will be the pathology findings, the pathology slide images, clinical data abstractions, and case photos after the required paperwork is provided. Additionally, CHAMPS includes a biorepository, so specimens can be requested along with the data for future studies, again with the main objective to try to reduce childhood mortality. So this time I'd like to acknowledge that we are very grateful for the parents and the family members, as well as the political and health officials and religious community leaders in the communities where we are who support this work to better define what is causing childhood mortality. Of course, the Bill and Melinda Gates Foundation for the support and the opportunity to make inroads on this immensely important topic, as well as colleagues in the sites where CHAMPS is active and our key partner organizations and a wide array of stakeholder organizations who support the work of CHAMPS. And ultimately, hopefully, we'll use CHAMPS data to reduce child mortality. This is briefly just, again, the 7 sites where are currently active and the site PIs as well as institutions involved. And I'd just like to leave with a quote that we find very inspiring by one of our participants on the Global Partners Board about how CHAMPS is a unique opportunity to really get at the detail on the cause of death and pattern of disease in children that could uniquely contribute to more effective interventions, both to prevent illness and, more importantly, to prevent death. Thank you.